name's Andrew and I'm here to talk to you about a discharge summary format that's called Handover to GP. When we have discharge summaries, the purpose can seem kind of simple. The idea is to summarise their admission at the point of discharge. However, there's a bit more complexity to this. It depends who is the audience that we're writing to and what is the purpose of the summary that we're providing. Sometimes we summarise things for research purposes so that we can audit and collect data to better understand how we provide quality care and do research. Sometimes we're summarising because we want to summarise on behalf of the patient for themselves or their family members. Sometimes we're summarising it for their primary care physician, who's usually a general practitioner. And that's a really important summary as well. Again, a different audience and a different way of summarising events. So as we consider who is the audience, and that may even be the next time they're admitted for the next team, but who knows whether that will be next month, next year, or next decade. We need to think about what is the purpose and therefore what is the content. And unfortunately, we have many institutions that do not have a very clear content that's prescribed to their junior doctors in writing summaries, although we do have some units who do that. So the Handover to GP format is one that says our primary audience is going to be their general practitioner, and secondarily to that is going to be the consumer or the patient and their family members. And then the tertiary function there is to summarise the admission for other admitting teams in future. So that's the audience, and the audience will then naturally help dictate what is going to be the content, because we need to consider what is that audience looking for when it comes to a summary of their admission at the point of discharge. So we went to general practitioners after deciding that our format would focus primarily on a clinical handover of care to general practitioners, and we asked them what they wanted. And they had pretty clear ideas about what they did want, and they had clear ideas about what they didn't want as well. So some of the things that we really wanted was they wanted a succinct summary, not a long summary. They wanted a summary that had the key events and decisions that was neatly summarised, any new or changed diagnoses, any items that they needed to specifically follow up, and if it was urgent, a phone call to actually make sure that was done. They wanted medication changes and the rationale for why those changes were made. They were looking for key investigations, and they wanted contact details, so if there were things that they needed to clarify, it was easy to get in contact with someone from the team that looked after their patient. Sometimes that can seem like really simple requests, but those things are not always covered by your average discharge summary. Some of the things that they were clear about what they didn't want were they didn't want really long summaries where it was hard to get a quick snapshot on what had happened, or that you had to read through a lot of detail to actually get to the main points. They didn't like inconsistent formats where the same patient may get discharge summaries that looked completely different from one unit to another. They didn't appreciate when there were incorrect GP details, so the correct GP never got the summary, but maybe their old GP from 10 years ago did get the summary. They didn't appreciate delayed distribution, so being able to produce a relatively quick but clear summary that can then go with the patient or to the GP on the day of discharge was really valued. They didn't want to have excessive investigations included, they just wanted the key points. And they didn't want to have a lack of detail surrounding the medications and any changes that were made. Lastly, they noticed that a lot of discharge summaries put a lot of detail into the patient demographics, something that the GPs didn't need or value. So when we set out to create this handover to GP summary, we had very clear goals in mind. We wanted to have a very clear, structured format. We wanted to have prescribed, succinct content. We wanted to summarise very specific events that went on within the summary, within the admission. We wanted to include specific medication details and rationale for changes or why things were commenced or ceased. We wanted to have really clear discharge plans for the general practitioner as well as for whatever the hospital was providing for that patient moving forward. And we wanted for all of this to be able to be produced really quickly and distributed easily. So the Handover GP format takes a page from the ISBAR clinical format. It has the I, S, B, A, and R sections, and I'll go through that in a bit more detail. But very simply, the introduction is the patient details and which team was looking after them. The situation should be summarising the reason for presentation. The background is a summary of their past medical history. The assessment is where the key issues and the management during admission is summarised. The recommendations summarise the discharge planning. And then lastly, added to ISBAR are the investigations, where we've defined key investigations to be included only, and medications, which will be included after the clinical synopsis, where we focus on the changes and rationale and an updated complete medication list. Let's break down each of those areas. The first thing to say is when we're generally writing these summaries, we need to keep in mind the principles of minimal use of acronyms when summarizing clinical details and avoiding the use of specialist terminology. So we really want to have it that any practitioner of any specialty or generalist could read this and understand every point that was being said. And even more so, because our secondary audience is the families and the patients themselves, we wanted to have the terminology that is easy to understand even for a layperson. So we wanted to make sure also that the language that's used is non-judgmental, to the point that if the patient or family read it, that they would be comfortable that it is clearly summarizing things in an objective format. So in terms of the introduction, a lot of this is automatically filled in. It's the patient details, their address, their date of birth, their full name, and it should have the consultant that was primarily responsible. That's usually automatically added. But something that's not always added, particularly in our context using electronic medical record, is the particular team that they were admitted under. So even just quickly summarizing with cardiology admission or surgical admission or hematology admission makes it very clear to the general practitioner who was looking after that patient. In terms of the situation, we want to know, why would this patient come to hospital? And very briefly, it's just 2 lines. The profile that says the background profile just prior to admission of the patient, what their function is like and who they live with. And in terms of the presenting complaint, just 1 line that says, encapsulates the reason that they attended hospital. What we don't want to include here is a very detailed history of presenting complaint. It's not really important for the GP to know that, and they're not particularly interested in that because it usually doesn't change any management. We're not interested in examination findings at the point of admission. We're not interested to summarize the medications at the time of admission, nor are we interested to summarize the initial investigations and results there. It's really just a 1 line for profile, 1 line for the presenting complaint. Next, we move on to the background, and this should summarize a list of their past medical conditions with a little bit of detail added. And this is just to make sure that everyone's on the same page in terms of their background and the level of detail that's there. It shouldn't be comprehensive, but it should provide a really clear snapshot with some idea of severity and key management points of some of the medical conditions that that patient has. And then we move on to assessment. This is a really important part that will summarize what are the key events that have gone on during the patient's admission, and what are the key points of management that occurred, and maybe even some of the key investigations that help guide the diagnosis and the management. There are some particular details that people are looking for, both in terms of hospital and general practitioners. Instead of summarizing generically in terms of antiemetics or antibiotics, we're looking for specific medications that were used and often durations, and antibiotics are particularly the ones that we want to know. And this can be so helpful when we look back and go, how long was this patient treated for? If this is an infection that's recurred, did we actually undertreat it? And can we easily access that information without having to dig through the records? So being able to summarize that, and even such things as going, this person has a penicillin allergy. Have they ever had cephalosporins, and is that something that's been established safe to give? If you look back and the summary clearly says this person received ceftriaxone for 5 days, you can with confidence prescribe that medication again, or a similar medication in the same family in the future. The other thing that we really want to summarize is changes to the direction of the care or advanced care planning, and particularly in terms of resuscitation statuses. And that can be really important in any key decisions made with the patient and their family about the direction of care made. So lastly, we come to the recommendation. This is about their discharge planning. Firstly, just to state, what is the discharge destination? For most people, it's going to be going home, but maybe the discharge destination is somewhere temporary, like rehabilitation, or maybe it's somewhere that's different, a change of their usual residential address, as that can occur during admissions, where perhaps they've had to move in with family members because they require more care, or perhaps they've had to move into a permanent residential aged care facility instead of from their home. And it's a really important point to know. Also, we're going to divide their plans for discharge into the outstanding investigations and specifying in every situation who is responsible for following up that result. The plan management by the hospital, where we as a hospital take responsibility for certain items of their ongoing care, and then the requested management by the GP. And even the terminology that we're using here is really key. We are partnering with general practitioners as hospital teams in looking after these patients. And it's important that we are requesting things, not stating that things will be done. So I think we need to really avoid terminology such as GP to chase. General practitioners don't always feel valued and respected in that kind of terminology. Instead, making requested management of the GP. And it's really important here, if there's anything that is time critical or of high importance, a phone call needs to occur, even if it's just to pass on that message to a secretary that can later give it to the general practitioner, but ideally actually talking over the phone to that GP so they know a discharge summary is on its way, the patient is being discharged, and here's a really key thing that we'd like them to chase up in a particular timeline. Lastly, including the key contact details for the admitting unit. And ideally here, you're actually going to put a name to that to say that this is the person who would be best to contact, or this is the person that looked after the patient and summarized their admission during the discharge summary. So there's, after this IS bar, there's also going to be investigations, and then following investigations are going to be medications. So in terms of investigations, we really need to include just the key investigations. So not just all their bloods at discharge, not all the tests at admission, the key scans or pathology that help define a diagnosis. For example, perhaps a new cancer, including the histology and the staging scans would be really important, but not necessarily including their CBE and biochemical profile. But if you had someone that had an acute kidney injury, for example, or some kind of liver dysfunction, putting their tests of those particular organs at discharge is important if the part of the management is to follow up changes in those results. So really you can summarize what we're looking for are key points of diagnosis, and that could be scans or biopsies are going to be most common there. And the second thing is results where we are asking someone to follow up a change in that result later on. We need to know that at the point of, at a certain baseline scan or baseline result at the point of discharge, where we're starting from so that we can know where it's changing to later. But general practitioners do not want to get an exhaustive list of investigations, they just want the key things. And some of those can even be included even more briefly within the discharge summary if it's worthwhile doing that. I've included here a couple of summaries. Firstly, a general surgery admission, and then secondly, a cardiology admission, which uses this handover to GP format. And you can take a moment to look how we've applied some of the principles that are there, such as non-judgmental terminology and avoiding the use of clinical acronyms to make discharge summaries really clear. And even overall, you can see, even with an admission that may have taken some days or a week or more, particularly in the case of the cardiology one, we've been able to neatly summarize the events in terms of the key points of management and specified certain medications that were used. And in terms of the discharge summary, we've made it very clear on discharge who is responsible for what part of their management. So I hope you find this very easy to use. This could be deployed in an acronym expansion very easily within a discharge summary. And this, I hope, will make a much easier tool to produce high quality, succinct and directed discharge summaries, with the primary audience being the general practitioner and the secondary audience being the patient and their family. Thanks for listening.